Our final speaker tonight, going from pregnancy, we're just going to move into the paediatric population, and we're lucky to have Dr. Matthew O'Brien with us. He's a paediatric infectious disease specialist and general paediatrician at Monash Children's Hospital and also the Monash Kids Hospital in the Home. He's a medical lead for Sotrovimab at the Monash Kids and other interests outside of COVID. Perinatal infections, including HIV, paediatric invasive fungal infections, and paediatric borderline ulcer infections. So thanks very much, Matt, for joining us, and I'll hand over.
No problem. Thank you very much. I'll just get the screen up. So yeah, we're going to do a very, hopefully, brief overview, a little bit more of the clinical stuff in relation to COVID-19 in children, and talk about the pathway as well. And then we can add some questions at the end. So obviously, most of these you could talk in quite a long detail, but we'll try and give a brief overview of these topics. But before we do that, I had to do the obligatory photo of myself and my family with the Premiership Cup after such many years of pain and despair. This is at the Sereno Hotel last Saturday, and I'm not sure if I'm more proud of my children or the Premiership Cup. And our family believing in indoctrination for my children. So, as to COVID-19 in children, so are children at risk? Yes, of course they are. Any child, any age, and the data nationwide from January to October for the 5 to 11-year-olds we picked out. There was more than 7,000 cases nationwide and 244 admissions to hospital. There's an asterisk on this because a certain proportion of those, particularly from New South Wales, were admitted for social reasons, in that their parents were also had COVID, were not in a position to care for them. So that skews that admission data a little bit. Can children be reinfected? Yes, but the reinfection risk appears very, very low. And how severe is the disease in most children? And I think everyone knows that overall the symptoms are generally milder in children than in adults. And 98% have symptoms that would be classified as either mild or asymptomatic, with about 2% hospitalisation rate. The mortality from the UK is about 2 per million in the paediatric population. We have had thus far 2 cases in Victoria that have died. Both have been over 10 and both have been associated with significant comorbidities. And in fact, they died with COVID as opposed to of COVID. And we've had no deaths in the younger age groups. Those who are at risk, and I'll come back to this, of more severe disease are those with comorbidities. Why is it less severe in children? We still don't really know. It's perhaps a less intense immune response. Perhaps there are lower viral loads in the respiratory tract. Perhaps there's different expression of receptors. We're not entirely clear. Can children transmit? Yes, they can. Although transmission in the younger age groups is less common, particularly to adults other than their household, it still can occur. If a child becomes very unwell, do we have any therapies? 12 months ago, we didn't have a lot, but we do now in terms of antiviral medications, immunomodulators. So dexamethasone particularly is the first and perhaps most useful, as well as budesonide, baricitinib, and tocilizumab. And we also now have prophylactic therapies for children with risk factors for severe disease. I'll touch very quickly on that. So I'm sure most of you know, most of the symptoms are in the first 5 days of the illness, which also coincides with their peak infectivity. Rash is quite a reasonably common symptom in children, and it is not necessarily indicative, though can be, of a sort of evolving inflammatory syndrome. But we know that COVID itself can have a rash, and the rash is non-specific. It can be erythematous, it can be urticarial, but we've found anecdotally that quite a lot will have an associated rash. There are a lot of potential complications, but the reality is we don't see many. The one of asterisks is PIMS TS, and I'm sure you've all heard or have some understanding of that. We've had 2 patients over the weekends with PIMS TS, so that's perhaps almost one of the most significant complications in regards to COVID-19. And the phenomenon of long COVID in children is not really understood that well, but doesn't appear to be as common as adults. So basically, which children are we seeing that are ending up in hospital the most? There's three groups of them. Then there's the infants and the young toddlers, and their primary admission reason is for dehydration. So gastrointestinal symptoms is actually a lot more common in the younger ones, and the group that get admitted there are usually brief and they require a bit of fluid support and then get home. The big group with the respiratory distress are the almost adults. So the teenagers, almost invariably the teenagers, and almost invariably with a comorbidity of having an increased BMI are the ones we're seeing here. And the third group is the one I just alluded to, the post-COVID complications and PIMS-TS. And as I said, we had 2 over the weekend. So some basic red flags: increased difficulty breathing. Chest pain is a really difficult one. We know that sort of 5 to 15% of children in the first week of illness who don't have significant cardiac complications or other complications, but just secondary to COVID illness themselves will present with chest pain. It's more frequent in the older children, usually lasts 1 to 3 days. So we know that's commonly associated with COVID, but obviously can be a sign of complications such as myocarditis or pericarditis. So that's always a difficult one to ascertain. And if there's any doubt, then our advice would be to send them to, ED for an ECG and troponin. Persistent fevers are a big red flag. So most children will only have fevers for a day or two, and if they're getting persistent fevers more than 5 days, or they develop new fevers, then we get concerned particularly about an evolving inflammatory syndrome, dehydration, and some of the other KD type phenotype clinical features, which I'll come back to in a second. Just very quick on the you've probably seen this or a similar one, in that the peak viral loads are in the first week of the illness, and most of the children have mild illness, and they're by the end of the first week, if most of them are starting to improve. And the ones we worry about who end up in ICU, they're the ones who progress with their respiratory deterioration towards the end of the first week into the second week. So risk factors for severe disease in children, as I alluded to, the single most common factor is a BMI in the teenagers, more than the 95%. Neurological disorders, feeding tube dependence, diabetes, chronic lung disease, congenital heart disease are all associated. I'll just pull up a couple of studies. This one is American data, and you can see from that, both in the little ones under 2 and those in 2 to 17, chronic lung disease is significant. Neurological disorders is significant. Diabetes appears to be significant. But it's less clear on some of the other conditions that we, before the data emerged, we suspected children would have a problem with. Immunocompromised is an interesting one. Our natural inclination is that these children are probably at increased risk of severe disease, but in several studies, and I'll pull up the next one, this is Canadian data as well, it actually doesn't come out significantly. I think there's still a bit to go on that, and all of us would be very cautious of, and we are quite proactive in treating children with immunosuppression. But it's just interesting, the ones that have thus far come out as associated as risk factors for severe disease. And you can see at the top again, obesity is again a very high, as it is in the adults as well, risk factor for severe disease. I won't touch too much more, but sotrovimab is now also available for children. We're very thankful for the adult ID team, Lydia and the team, for incorporating pediatric age patients into the program. So we also would encourage consideration of any patients who you think might be at higher risk of or be eligible for sotrovimab. So it's similar to the adult criteria, in that they have to not have an oxygen requirement, not be fully vaccinated. They need to be more than 40 kilos and more than 12 years. The symptoms have to have been there for 5 days or less. And that's the kicker a lot of the times, in that by the time we are getting the referrals at sort of day 5 or day 6, and we've missed the window for that. The last one is they either have to be immunosuppressed and they can be fully vaccinated, or have a significant comorbidity. And ours is similar to, there's a list of the immunosuppressed ones. I won't go through that too much, but in terms of comorbidities, the ones we really are trying to target, a little bit different, obviously, from the adults, in that we try to ideally capture our kids with CF, with congenital heart disease, with severe asthma. Obesity is also there, and there's this non-specific title or criterion of pediatric complex care conditions, which includes a lot of complex pediatric conditions. And most of these, if you think you have a patient who may be at increased risk and they potentially make the eligibility, then it's the same referral process that we do for the adults. It comes through the same infusion clinic website, and then the referrals and then the pediatric ones, when they're potentially available, come to either me or one of my ID consultant colleagues. And and in terms of the PCC things, that comes down to a bit of individual case by case decision making on those ones. But again, if there's any doubt you think they may be eligible, then we certainly welcome referrals. I'll very quickly touch on this because it is significant and it is expected to potentially continue as our case numbers are large, and that's the multi-system inflammatory response syndrome, known as PIMS-TS or MISC-C, depending on which part of the globe you live. It is rare, although it's a serious condition. It's essentially a delayed severe immune response to the presence of the virus, and there's 3 phenotypes. There's a KD type phenotype, so a Kawasaki's type phenotype. There's a shock-like, like a toxic shock-like phenotype, and then there's a third category, which is undifferentiated or basically a non-KD, non-shock phenotype. They're generally the older children. They have GI symptoms that predominate, and any of the 3 phenotypes can be associated with cardiac complications like Kawasaki's can, particularly in terms of coronary aneurysms, but also myocardial dysfunction. PIMS-TS is more common in the 6 to 12-year age group. We normally would sort of be more aware of Kawasaki's in the under 5s. The PIMS-TS can occur at any age, and it occurs, it's not in the acute phase of the illness, so it's not in the first week. It's generally 2 to 6 weeks afterwards, and often it's not related to the severity of their COVID illness. Often they've been either asymptomatic completely or have had very mild symptoms. We had one who's an inpatient at the moment, whose brother tested positive and other household contacts tested negative. He had no symptoms, but he developed full KD type PIMS, and serology was positive as well. Essentially, who do you think about it? You think about it in someone who's had COVID, who's 2 to 6 weeks after, new fevers, chest pains, palpitations, prominent GI symptoms, and they have very prominent raised inflammatory markers. Here's a nice graphic from which sort of illustrates the kind of inflammatory signs that we see. So a lot of crossover with Kawasaki's disease, both clinically and biochemically, but not always, depending on the specific phenotype. And generally, persistent fever is the thing that we really would start to really consider. And persistent fever, depending on your definitions, is either 5, 3, or 24 hours. But if you're getting someone who's got a couple of days of fever at least and had COVID recently, it's worth thinking about. I'm going to very briefly touch on immunisation. I'm sure you all know that at the moment we're only immunising 12 years and over. There is 5 to 11s. The trial data is still being reviewed by the regulators. We are only eligible to give an mRNA vaccine. Obviously, there's a lot of conversation around vaccine, but it codes for the spike protein, which stimulates an antibody response. It doesn't combine into the DNA in our cells and is actually very quickly broken down and cleared away, and is highly, highly efficacious in children. Generally very well tolerated. The most common and concerning feature is the acknowledged rare but definite risk of pericarditis or myocarditis. This is highest in adolescent boys after their second dose, and it usually occurs within 1 to 5 days of the vaccine and presents typically with chest pain, shortness of breath, or palpitations. So the numbers vary depending on where you read, but again, the highest is 16 to 17-year-olds and about 69 per million based on US data. Just keeping in mind, and it's something worth counseling with your patients, there is a significant risk of myocarditis with COVID-19 itself, and again, it's felt to be, even in children, more than the risk of associated pericarditis or myocarditis post-vaccine, anywhere up to 6 times the risk. But that data does vary, but it is worthwhile reminding patients of. And also, there's about 3 to 8 cases of myocarditis and pericarditis that are nothing to do with COVID vaccination every week in Australia. So it's worth keeping that in mind as well. Very quickly, in terms of the pediatric medium risk pathway, these are the usual sort of criteria. So very similar to sotrovimab criteria that we would routinely take on to the medium risk pathway. If there's any questions about eligibility, there's a number there. The top one for the Monash Pathway team leader, and an out of hours contact. And there's also a on-call consultant who's either one of the general pediatricians, one of the respiratory physicians, or one of the ID physicians on a rotating basis. And if there's any uncertainty regarding a patient's eligibility or any questions about a patient who's on the low risk pathway, you're more than welcome to ring through to the team leader or the on-call consultant. Just a couple of resources for children there, and I think that's pretty much it.
Fantastic. Thanks very much, Matt, for the presentation, rounding out what I think was a fantastic set of presentations to give us a real overview of what's going on in the COVID space.